Our next topic is Duchenne muscular dystrophy, which is a severe type of muscular dystrophy that primarily affects boys. Our next speaker, Dr. Ivan Lehman from Croatia, will speak about Duchenne muscular dystrophy. He works as a pediatrician at University Hospital Center in Zagreb, Department of Pediatrics, Institute of Neuropediatrics, and meet in his daily activity children with neuromuscular disease every day. He published many scientific papers, scientific articles dedicated to neuromuscular diseases. More about this topic from Dr. Ivan Lehman. Welcome, Dr. Ivan Lehman, and thank you very much for sharing your experience with us today.
Yes, thank you. Thank you very much, and good day to everybody. It's really an honor for me to be participant in this conference. I will give today an overview of Duchenne muscular dystrophy that is really frequent found among muscular dystrophies. And also there is some improvement in the therapy of Duchenne muscular dystrophy that has been seen in the last few years. When we talk about muscular dystrophies in general, it is a group of inherited usually non-inflammatory disorders that affect muscles, and they are really rather different. They can present from early childhood to adulthood. Distribution of muscles that are affected can be different in certain types of muscular dystrophies. Also, the mode of inheritance can be different. Lots of muscular dystrophies can affect heart muscle. That is also another medical issue that can be a really important topic when discussing muscular dystrophies. Among all muscular dystrophies, Duchenne muscular dystrophy is actually the most common one, and its milder variant, Becker muscular dystrophy, is the second most common muscular dystrophy of all. When we talk about Duchenne muscular dystrophy, it is really a progressive disease, a severe one. And as you can see on this graph, actually each patient deteriorates, and it happens really quickly. The first symptoms manifest, usually clinical symptoms manifest usually around the second or the third year of life, usually problems with the gait, with climbing the stairs, frequent falls, and it is progressive, and patients become wheelchair bounded at the age of about 12. Respiratory insufficiency is the main problem, and it happens usually in the late teens or early 20s. When we talk about the cause of the disease is caused by the mutation in the biggest gene in human genome. It is called the DMD gene, and it has 79 exons. And as you will see a little bit lately, it is actually a problem for some sort of the therapy. The gene is placed on X chromosome, and the disease is inherited X-linked recessively. It means that women are carriers and the boys are affected. The protein is called dystrophin, and its function is to connect contractile filaments to cell membrane complex. And without the dystrophin, the cell cannot keep its integrity. The frequency of dystrophinopathies, and when I say dystrophinopathies, I mean a spectrum of diseases that is caused with malfunction of the dystrophin, is 1 in 6,000 to 1 in 5,000 newborn boys, and more than half of them have the most severe type, Duchenne muscular dystrophy. Prevalence of DMD is 63 per million, and it is much more frequent than its milder form, Becker muscular dystrophy. Women get DMD really rare, less than 1 in million, and usually it is due to some chromosomal rearrangements or other genetic causes that are rare. When we talk about women carriers, even some of them, up to 20%, can have some muscle problems or weakness, and up to 17% of women carriers can develop cardiomyopathy. The disease is inherited, but 1/3 of whole mutations arise de novo. That means that not all mothers of boys with Duchenne are carriers. And what is the goal in the future? The goal is to get optimal care of patients with Duchenne muscular dystrophy. Optimal care means better survival in the end and better quality of life. How can we achieve that? It's by following standards of care, especially dealing with cardiopulmonary complications, but also, as I will show later, we can expect some improvement in pharmacotherapy of Duchenne muscular dystrophy. Now I will say a few words about mutations. It is important for the establishing diagnosis, but also for the treatment. So as you can see, the spectrum of the mutations is almost the same everywhere in the world. Some mutations are more frequent than the others, and the most frequent mutations are large deletions and duplications. Those are deletions that affect the whole exons of the gene, or duplications, but also there are some other mutations, small ones like small deletions, small insertion, and point mutations that are also important for the therapy. But among all the patients, majority of the mutations happen between the exons 45 and 55, and it is called the hotspot region for the mutation. So we have lots of mutations, thousands of them. So there is a question, is there a connection between genotype and phenotype? Can we predict the phenotype, a young boy diagnosed with mutation in dystrophin gene? Actually, in most cases, we can. And the key is if a mutation causes a frame shift in reading frame. So the mutations that cause frame shift usually cause the patient to have Duchenne muscular dystrophy, and mutations that are in frame usually cause Becker muscular dystrophy. But there are a few exceptions to that rule. So here is an example. This is normal dystrophin, and if a patient has deletion that is out of frame, then the synthesized protein will not be functional, and the patient will manifest Duchenne muscular dystrophy. And if the mutation is in frame, then the protein will be shorter and it will not function perfectly, but it will function at some level, and the phenotype will be a milder one, Becker muscular dystrophy. And I want to say here that nonsense mutation, that is a single nucleotide change that causes mutation that leads to premature stop codon, causes a severe type Duchenne muscular dystrophy. I will explain that a bit later. Can we check when we have results of gene testing? Can we check it if mutation is in frame or out of frame? Yes, there are some reading frame checkers on the internet that are freely available. And if you put in starting exon and the last one that is deleted or duplicated, then you can check if the mutation is in frame or out of frame. But I want to emphasize here that it is not 100%, as you saw earlier. There are some patients that have, especially for certain exons, that can have out of frame deletion, but still milder type, but those are rather rare. And what happens with the muscle when there is no dystrophin? When there is no dystrophin, cells goes through certain pathophysiological processes that finally lead to a loss of muscle fibers that are replaced with fat and connective tissue, usually due to ischemia of the muscle, oxidative stress, influx of calcium also, an inflammatory response that all lead to cell death. And then the muscle fibers are replaced with other tissue that we can see on muscle biopsy. Also, on muscle biopsy, we can check with immunohistochemistry or other methods if there is dystrophin present at all, and so we can prove that the patient has dystrophinopathy or Duchenne muscular dystrophy if there is no dystrophin at all. Clinical presentation. First of all, laboratory signs and histological signs are present since birth. That is something that maybe in the future we can use for newborn screening for Duchenne muscular dystrophy. Nowadays, there is still no adequate therapy for all patients with DMD, and criteria are not completely fulfilled for newborn screening to be introduced everywhere. So the first signs are muscle weakness that present usually at the age of 2 or 3 years of age. It affects primarily proximal muscle on lower extremities. So boys have difficulties in running, jumping, climbing stairs. They are slower than their peers of the same age. The gait is typically waddling, and boys develop lumbar lordosis, and there is pseudohypertrophy of calves that is actually connective and fat tissue that is one well-known sign of dystrophinopathy. Sometimes early in the disease course, boys can complain of pain in their muscles. And as I said earlier, disease is progressive and patients lose their ability to walk at the age of 12, most of them. Some can walk a bit longer, and some of them lose the ability earlier. When they stop walking, they develop, almost all of them, neuromuscular scoliosis, and scoliosis is one of the causes for deterioration of lung function. Laboratory signs can be present or are present since birth, and the well-known biomarker of dystrophinopathies is creatine kinase, CK, and its levels are pretty high in dystrophinopathies, the highest in Duchenne muscular dystrophy, and as the disease progresses, they become lower during the years. There are also increased levels of liver enzymes, aminotransferases, but they are not actually from the liver, they are muscle enzymes. And this is sometimes patients with Duchenne dystrophy early in the course of the disease are being treated or diagnosed as liver patients, but that is not the case. Cardiomyopathy is also can be present in patients with DMD. It develops later, a bit later during the course. So 1/2 of the boys have cardiomyopathy at the age of 18 years. It is not actually symptomatic till the late stages of the disease. So heart ultrasound should be done in patients with Duchenne, but also boys can have conduction disorders. So ECG is also suggested. During the course of disease, there are multiple complications, and the important one, all are important, but maybe more important ones are orthopedic complications like contractures and scoliosis, but also bone fractures If a patient has bone fracture, it can make him to lose his ambulation much early. So bone health is one of the topics that has to be cared in DMD. Pulmonary function deteriorates, and at the age of 16, usually vital capacity is less than 50%. And when that is the case, that can lead to acute respiratory failure during respiratory illnesses. Some patients with Duchenne have cognitive functions affected and have behavioral disturbances, even some cognitive deficit and psychomotor development delay. Those are actually characteristics of DMD. Boys can have autism spectrum disorder, problems with attention and hyperactivity, anxiety, but some patients have normal IQ and even above the average. So that is not the rule for all, but sometimes it can suggest disease in young boys, cognitive problems. This is a diagram that shows disease progression. There are a few phases, and the first one is called pre-symptomatic stage. Nowadays, we are developing new therapies, so it is expected that Duchenne should be diagnosed early. So developmental delay, positive family history, or elevated CK should raise concern about possible dystrophinopathies. So as you can see in the beginning, boys can improve due to psychomotor development, but then they reach a certain plateau, and then the disease causes muscle decline, and they in the end become non-ambulatory. To establish the diagnosis nowadays, one should try to have molecular diagnosis or gene analysis positive, and it is not always possible. So muscle biopsy still has its role in diagnosis of DMD, but that is really, really rare nowadays. So what should raise concern that there is possibility of DMD? It is delayed motor development in a patient with positive family history, or actually any problems with the muscles, such as head control, difficulty running, jumping, frequent falls, muscle pains, myoglobinuria, or some cognitive problems, speech, learning, behavioral disturbances. In a patient with positive family history, those signs should be indication for gene testing. Otherwise, if there is delayed psychomotor development, especially if a child doesn't walk till the age of 16 or 18 months, or have clear signs of proximal muscle weakness. Also, unexplained elevation of aminotransferases should be a sign to check CK. And actually, CK is elevated in 100% of patients with DMD, and it is also elevated in 100% of patients with Becker muscular dystrophy. So if CK is normal, then you can rule out dystrophinopathy. And the diagnostic process is, if you have a suspicion that I explained earlier, you should test for CK. If CK is elevated, then gene testing for deletion or duplication. This test will cover a majority of mutations, and it is a cheaper test, and I think it is done widely in lots of institutions. If this test is negative, we still didn't rule out Duchenne, then genetic sequencing is indicated. And if that is negative, then this is the reason for muscle biopsy, because there might be some intronic mutations or other that are not present in the gene. But testing for deletion of exons or duplications will cover majority of mutations. Treatment. of the Duchenne, it is not like in some other disorders like SMA that we will hear lately, but there is a significant progress in the last years, but still there is no cure for dystrophinopathies. Treatment is multidisciplinary, consists of pharmacotherapy, physical therapy, surgical treatment, and other therapy. I think multidisciplinary approach is still a problem for some of us, and it is not always easy to have a real multidisciplinary team that will be functional and especially that will be patient oriented. Not just patient oriented, but multidisciplinary approach should be appropriate for the certain stage of the disease. And as you can see here, actually, lots of specialists and lots of medical workers should be involved in multidisciplinary team for Duchenne muscular dystrophy. And this is actually nicely explained in standards of care for patients with DMD, and there is a really wide range of experts that should take care. And as I said before, we should try to be patient-oriented. And now I will say a few words just about available pharmacotherapy. Nowadays, corticosteroids are most important therapy in patients with DMD. They should be started before the significant decline in muscle function that is usually at the age of 4 to 5 years and never before the age of 2 because side effects of corticosteroids. And it has been shown that corticosteroids really do improve muscle strength and muscle function, and they prolong a bit ambulatory phase, but they also not improve, but slow deterioration of pulmonary function, and they can delay the development of cardiomyopathy. Usually 2 corticosteroids are used, it's prednisone and deflazacort, and there are still some discussions about the regimen of taking the steroids, and it is still not fully known what is their exact mechanism of action in Duchenne muscular dystrophy. Nowadays in Europe, we have a drug that is used in patients with nonsense mutation. It is point mutation that causes premature stop codon in DMD gene. This mutation is present in 10 to 15% of boys with DMD, and the drugs works on ribosomes to skip the premature stop codon. It has been shown in clinical trials that it slows deterioration of results on 6-minute walking tests only in certain group of patients. But as it can be shown later, it really helps a bit in the loss of ambulation. It prolongs the time that the patient is ambulatory. And more than that, it lowers deterioration of functional tests in patients with DMD. Ataluren is registered in Europe and not registered by FDA. Another group of the drugs that exists are antisense oligonucleotides used for exon skipping. The idea is if you have out-of-frame mutation and there is possibility to skip some exon nearby to make out-of-frame mutation to become in-frame mutation and theoretically to change Duchenne phenotype to Becker. So this is the idea, and it is applicable only for certain mutations. You have to check if a deletion is applicable for certain exon skipping medication. And it has been shown that it really do improve dystrophin expression in muscles, but still it is from, for example, from 0.2 to 0.6% of normal dystrophin. And because of that, European agency didn't approve application of exon skipping therapy, and it is improved by FDA, but mostly due to dystrophin expression and not always due to clinical results. Besides eteplirsen, there are also other exon skipping drugs that are used for skipping other exons. And finally, I do hope that we will see this in future, maybe near future. It is gene therapy for Duchenne muscular dystrophy, but there is still a problem. As I said, DMD gene is a huge one, and it is too big to be put whole in a viral vector. So the idea is to use a shorter variants called mini dystrophin or micro dystrophin to introduce a missing gene to a patient. There are actually few clinical trials, and the drug is still, all of them had some problems, but I think we can expect that it will happen in the future, but still gene therapy is not yet in clinical practice. There is also possible, and it is there are some clinical trials of cell therapy, especially for cardiomyopathy, and some other drugs are being tested. Some of them work. Some clinical trials are stopped. Vamorolone is corticosteroid that is used because of less side effects, and some other drugs that actually work on muscle and try to prevent their deterioration. So in the end, we have some improvement in therapy of Duchenne muscular dystrophy. It is a really severe disorder that affects boys, the most frequent muscular dystrophy. We will have to try to have good expression of dystrophin in future therapies. It is expected that 30 to 50% of dystrophin in the muscle should be enough for a patient to have less symptoms. Today, we still cannot achieve that. And today, we have some therapeutic options that we didn't have a few years ago. So thank you very much for your attention. I tried to give you an overview of present situation with Duchenne muscular dystrophy. And thank you once again, and greetings from Zagreb, Croatia. This is our Christmas market, and if you are able, you are all invited to visit us. We are very proud of this, and I wish you all happy holidays. Thank you once again.
Thank you very much for this overview, but also for your invitation to Zagreb. It's very tempting. I would like now to open the floor for the questions or comments from the public. Please just open your microphone and ask the question.
Maybe just one comment. Hi, Dorica. So very nice talk, Ivan. And as you mentioned, there are questions and issues around gene therapy for Duchenne due to the fact that there are different microdystrophin which could be expressed, which could have or generate some responses, immune responses from patients. So I just wanted to highlight the fact that most of the clinical trials trying to express microdystrophin unfortunately had adverse effects for a few patients. But the very, very positive, and that's really the message I want to carry, that's a positive message, is that whereas it never happened before for any pathology, all the competing companies came together to share their information about this adverse effect, to try to understand together how to improve their gene therapy treatment and how to overcome these side effects and increase the safety of treatment for patients. And so I think that's unique because before, usually these pharmaceutical companies were just competing and not sharing their information, particularly when it's about issues. They prefer to stay silent. And so just to say that one of the reasons why they accepted was because there were pressure from patient organization for them to share their data. So first, to let you know about this change in the pharmaceutical company way of looking at clinical trial, they understand now that for rare disease, they need to pull the data together to be able to understand what is going on. And second, that patients were really instrumental in convincing them to share this data. So even if you do not, fund the clinical trial or fund research, you can have a very important role to make sure that the one who are actually organizing this clinical trial are sharing the data and make sure that it increases the safety and efficiency of the treatment for all patients. So that was my message.
Thank you.
Thank you very much. If you want to intervene, Dr. Ivan.
No.
Okay. Okay. If there are other comments or questions, Arabella?
Yeah, I actually do have a question. First of all, I'm very happy to see you again, Dr. Lehman. We had the pleasure of meeting in Ljubljana in September. Yeah, so and I was happy to see that you are very engaged with patient organizations as well. So I don't have a very medical question, but I just want to say, because your specialty is actually children with Duchenne. So you have a lot of engagement with children and with children's parents and caregivers. Do you think, how do you see these interaction with the families and with the caregivers? Because I know I'm a mother of 2 children with CMP, not the same, but still with a disability. So I know for parents and for caregivers, this can be very challenging. And for us, it is so important if we find those kind of doctors that are very supportive and very understanding. And I really think that you are that kind of person. So do you have a special message for the families of children with Duchenne? Something that can actually raise their optimism, I don't know, encourage them? Because you are actually close to families, but also with to patient organizations.
Yes, thank you for the questions. I'm not sure if I'm an example for that, but I think that first of all, our role is to try to establish the best medical care for the patient. And I see that in my hospital and in our referral center, we still struggle with that, especially establishing multidisciplinary teams. So I think this is our first role as a physicians, to try to be good or the best in medical care, and we still have problems with that. What I can offer, I can't offer much. It is always good idea to listen to needs of patients, and sometimes, not sometimes, but patient organizations are the ones that can channel those needs, and that can put them in format, so you know what are the needs of the patients. And another role of the doctor is, I think, that one should be available for the patients, especially if something happens and if there are extra needs. It would be nice to have the opportunity to form excellent teams, to have some teams around the country, but I think it is maybe too big task. It's important to have a team, really good team at first at our hospital or in one's hospital, and then to improve the standards of care. So that is my opinion regarding that. And dealing with parents, I'm a pediatrician, so so yes, it is difficult sometimes. You are right, especially in severe diseases like Duchenne muscular dystrophy, and sometimes you have to engage parents. Some parents are really educated and they know about the disorder and about their needs even more than we do sometimes, but sometimes you have to try to engage the caregivers more. That is also my point of view. Thank you. I hope I mentioned something that you wanted to hear.
Thank you